Right. So a very good evening, everyone. So in this particular section, I'll be doing the quick revision of the diabetes mellitus, wherein I'll be discussing about the management in detail. And in detail, I'll be discussing about the insulin therapy. And I'll also be discussing about the CGM, that is continuous glucose monitoring. And I'll be discussing about the special forms of diabetes mellitus, that is latent autoimmune diabetes of adults and maturity onset diabetes of young. And also I'll be discussing about the acute complications, that is diabetic ketoacidosis, and some of the chronic microvascular complications like diabetic retinopathy and diabetic neuropathy is what I'll be discussing. And following which I'll be discussing 10 clinical based questions on the same topic. So this will be the content of the today's discussion. Okay. So the first important thing in any diabetes management is the lifestyle modification. So lifestyle modification, this plays an important role in the management of both type 1 and as well as the type 2 diabetes mellitus. So what all the lifestyle modification or lifestyle management include? So first and foremost, the education about the nutrition to the patient is very, very important. And that particular nutrition, it should be containing a carbohydrate restricted diet. Then next important is the physical activity, and how much of the physical activity is required, I'll be discussing now. Then followed by that, the psychological support. Then if at all, if there is any acute illness, if the patient develops, he need to take care of that acute illness, and then medications. So this will be in toto about the management of diabetes mellitus. And you also need to advise the self-management education. So the individual has to acquire, or the patient has to acquire the knowledge for the self-care, and he has to emphasize the psychosocial well-being. And in the nutrition, what is that I have discussed? Like as I was discussing that it is the carbohydrate restricted diet is what has to be advised in these patients with the diabetes mellitus. Now coming to the physical activity. So how much of the physical activity is mandatory in diabetic patients in order to have adequate glucose control is the individual has to do 30 minutes of brisk exercise for nearly around 5 days in a week, right? 5 days in a week. So that means in total, he has to do a brisk walking for nearly around 150 minutes per week. So that should be a form of moderate aerobic activity, right? That should be the form of the moderate aerobic activity which is required in the treatment of this patient, right? And along with this moderate aerobic activity, the resistance exercises are required, and as well as balance training is also very, very important. And psychological support is very important along with the nutrition and as well as the physical activity. So in the psychosocial care, right, depression, anxiety, stress, all these will impact the adherence of the medical management to the patient. So the individual should be psychologically very strong, and the psychological status of the individual should not be impacting the medical management of the patient. Next is the glycemic control monitoring. So how is that you need to advise the glycemic control monitoring is, one is SMBG, right? That is self-monitoring of the blood glucose, which is very important. And along with that, the individual has to do the monitoring of the HbA1c. So SMBG and as well as the HbA1c should be done mainly to assess both the short and as well as the long-term glycemic control. So that is about glycemic control monitoring. So if you take the SMBG, that is self-monitoring of the blood glucose. So in which group of individuals the frequent monitoring is very much required? Frequent monitoring is required for both type 1 and as well as the type 2 diabetes mellitus, right? Frequent monitoring, it is advised especially for type 1 and including the insulin dependent type 2 diabetes mellitus. Okay. So usually your type 2 diabetes mellitus is non-insulin dependent diabetes mellitus. But if a patient of type 2 diabetes mellitus has gone to a state of requirement of the insulin, that is the point when the frequent monitoring of the self-monitoring is important. Next is the continuous glucose monitoring. So continuous glucose monitoring, this will detect the glucose levels continuously. Now, in which scenario the continuous glucose monitoring is being done? it is done in those individuals who are using the insulin pumps for the automated delivery. Right? It is done in those individuals who are using insulin pumps for automated delivery. In them, the CGM is required. That is, continuous glucose monitoring is required. Now, you take the treatment. So the first important is lifestyle modification, in which the dietary control is very important, and followed by that, the aerobic exercise is very, very important. Then followed by that, the pharmacological treatment. Now, you see this pharmacological treatment, always it should be in combination with the lifestyle modification. That means that nutrition and as well as, right, the nutrition and as well as the aerobic exercise and the medication should be an add-on. So the combination of lifestyle and medications is very, very important part of the treatment. So pharmacological treatment should not be isolated. It should be given in combination with the nutritional support and as well as the aerobic exercise. Next is the insulin therapy. Now, insulin therapy, it is the preferred mode of treatment in case of the type 1 diabetes mellitus. And in the insulin therapy, like you have both, that is the basal insulin and as well as the bolus insulin therapy. Now, let me discuss in detail about the insulin therapy in case of the type 1 diabetes mellitus. Now, if you take this insulin therapy, in a newly diagnosed patients, how much of the insulin has to be started in case of type 1 diabetes mellitus? In case of type 1 diabetes mellitus, you need to start at a rate of 0.4 to 0.5 units per kg per day. Right, 0.4 to 0.5 units per kg per day. This should be the total daily dose. Right, this should be the total daily dose. Now, if you take the total daily insulin requirement, total daily insulin requirement. So total daily insulin requirement, that is typically, so the starting dose is this much. Right, start with 0.4 to 0.5 units per kg per day as the total daily insulin dose. But how much is the total daily insulin requirement? The total daily insulin requirement, this is typically around 0.5 to 1 unit per kg per day. Right, 0.5 to 1 unit per kg per day, depending on the glycemic control and as well as the lifestyle. So this will be the total daily insulin requirement. This will be total daily insulin requirement. Now, in that, you have the basal insulin and again the bolus insulin, basal insulin. So 50% of the total daily dose, right? 50% of the total daily dose, that should be the basal insulin. And what are the examples of the basal insulin? The examples of the basal insulin, that includes glargine, then followed by that detimer, then followed by that the decludec. Okay, so these are the basal insulin dose. Then coming to the bolus insulin dose, the remaining 50% of the total daily insulin dose will be the bolus insulin. Now, this bolus insulin should be divided into 3 meals as the rapid acting insulin. What are those rapid acting insulin? Either you can give regular insulin or Lispro, Aspart, or the glulicin. That will be the bolus insulin, right? And how much should be the insulin to carbohydrate ratio? So whenever you are giving 1 unit of the insulin, right? Whenever you are giving 1 unit of insulin, that will be covering nearly around 10 to 15 grams of the carbohydrate what the patient is taking. Then next is you need to know about what is called correction factor. What is this correction factor? It depends upon the insulin sensitivity within the patient. That is, 1 unit of insulin reduces the glucose by 30 to 50 milligrams per deciliter. That is the correction factor. So 1 unit, if you take insulin to carbohydrate ratio, 1 unit should be given for 10 to 15 grams of carbohydrate what the patient is taking. But if you take the correction factor, 1 unit of insulin, it reduces the glucose by 30 to 50 milligrams per deciliter. And it all depends upon the insulin sensitivity of the patient. Okay. Now, during which particular time the adjustment of the insulin dose is required? You need to modify the doses of the insulin based on self-monitoring of the blood glucose and based on the continuous glucose monitoring readings, right? And you also need to adjust the insulin dose depending upon hypoglycemia or hyperglycemia and as well as the exercise of the individuals, right? So now you have two forms of the insulin regimens. What are these two forms of insulin regimens? One is multiple daily injections. The other one is continuous subcutaneous insulin infusion. That is called CSII, right? Continuous subcutaneous insulin infusion, right? Then you take the special considerations. What are these special considerations? These special considerations include the exercise and as well as the illness. So during the exercise, right, what is that you need to do is you need to decrease the bolus dose of the insulin during the exercise, right? Just before the exercise, you need to decrease the bolus dose of the insulin, what actually the patient is taking. But during the acute illness, what happens is there is increase in the insulin requirement. Okay, there is increase in insulin requirement during the acute illness, mainly to prevent the diabetic ketoacidosis. So this is about the special considerations, right? Next, coming to the monitoring and as well as follow-up. So how is it you will do monitoring and as well as follow-up? That is depending upon, one is your SMBG, that is frequent blood glucose monitoring. The other one is the periodic HbA1c checkup has to be done. So this is about the insulin requirement. I'll repeat the insulin dosage. The starting dose in a newly diagnosed patient will be 0.4 to 0.5 units per kg per day. This will be the total daily insulin dose. But how much is the total daily insulin requirement? That is 0.5 to 1 unit per kg per day, depending upon the glycemic control and as well as the lifestyle of the individual. In this total daily dose, 50% should be basal and 50% should be bolus. And that 50% of the basal, you give that with either glargine, detimer, or degludec. And if you take that bolus, the 50% of the bolus insulin, that should be divided in 3 meals as the rapid-acting insulin, that is regular, Lispro, Aspart, and as well as glulicin. So this is about how you need to deliver the insulin in a newly detected type 1 diabetes mellitus. Okay, so this is about the type 1 diabetes management. Then coming to the type 2 diabetes management. So in case of type 2 diabetes management, the first thing again, lifestyle modification, right? Lifestyle interventions are very, very important. And followed by that, the medication. And in the medication, the drug of choice is the metformin. Now, why is that metformin considered as drug of choice among various oral hypoglycemic agents that we have? Why? Because metformin is the drug which will reduce the HbA1c maximally, right? So it will reduce the HbA1c by 1.5 to 2%. That is the reason why metformin is considered as the drug of choice in patients with the type 2 diabetes mellitus. Then we have many insulin sensitizers, and then we have insulin secretagogues also. Let me discuss what are the glucose lowering agents in type 2 diabetes mellitus. So in type 2 diabetes mellitus, the glucose lowering agents that includes bigonides, which is nothing but your metformin, followed by the sulfonylureas. You have first generation and second generation sulfonylureas, but we are not using the first generation sulfonylureas. What are the examples of the first generation sulfonylureas? That is chlorpropamide, right? Chlorpropamide and tolbutamide. These we are not using, but what we are using now is second generation sulfonylurea. And these sulfonylureas are the insulin secretagogues. Then we have the GLP-1 receptor agonist. These are usually injectable drugs that should be given in the form of subcutaneous injection. And these GLP-1 analogs include liraglutide and as well as the exenatide. Then followed by that, the SGLT2 inhibitors. SGLT2 inhibitors, these are the new molecules. They act at the level of proximal convoluted tubule, and they will inhibit the glucose absorption at the level of proximal convoluted tubule. And what are the examples of SGLT2 inhibitors? That is dapagliflozin and as well as empagliflozin. And these days, the SGLT2 inhibitors, it has been shown to reduce the mortality in patients with the heart failure. That is the added advantage of the SGLT2 inhibitors. And very important point is this SGLT2 inhibitors, they are associated with one of the very important adverse effect, that is the urinary tract infection. That is about the SGLT2 inhibitors. Now, what are the emerging therapies which are given in the treatment of type 2 diabetes mellitus? The emerging therapies that we have is the stem cell derived islet cells, right? Next is novel, that means new insulin delivery methods, then targeted immune therapies. These are the emerging therapies in the treatment of diabetes mellitus. Now, what are the adverse effects of these diabetic management? One of the very important adverse effects is hypoglycemia, because these insulin secretagogues, they increase the insulin secretion, and that can decrease the glucose levels of the individual. And whenever there is hypoglycemia, the individual will be continuously consuming their food, and that can make the individual to have weight gain. The other problems are the treatment related complications, because the drugs OHs, they have the complications. For example, you take metformin, which is a drug of choice. What is the adverse effects or complications associated with metformin? It can cause lactic acidosis. It can cause vitamin B12 deficiency. It can cause gastritis. And this metformin should be avoided when the individual goes into a stage of the end stage renal disease. So these are like complications which are related to treatment. So this will be the adverse effects of the therapy. Now you take acute hyperglycemic disorders. One of the very important acute hyperglycemic disorder is diabetic ketoacidosis. So in case of diabetic ketoacidosis, how much will be the blood glucose to call it as DKA? The blood glucose levels, it should be definitely more than 250 milligrams per deciliter to call it as the diabetic ketoacidosis. Okay. Now, so what is important part of the discussion is the CGM, because these CGM, these are the new devices, right? The continuous glucose monitoring, these are the new devices. You need to be aware of these CGM devices, because this being new devices, definitely there will be the expected questions. Now, what exactly you mean by the word CGM? As the word itself tells you, that the CGM devices, they continuously track the blood glucose levels in the real time using a small sensor which is inserted under the skin. That is the role of the CGM. These CGMs, we have two types. One, we have the professional CGM, right? And second, we have the personal CGM. Now, what do you mean by this professional CGM? Professional CGM is that it does intermittent monitoring by the healthcare provider. That is professional CGM. Whereas the personal CGM is that it is a continuous daily use by the patient. That is the personal CGM. Now, what are the components for the continuous glucose monitor or the CGM? It has the sensor, it has the transmitter, and it has the receiver. These are the three things, or these are the three components: sensor, transmitter, and as well as the receiver, right? And these receivers, usually they're in the form of apps in the smartphones. Now, what is the mechanism of action of this CGM? What the CGM does is, the sensor, it measures what is the interstitial blood glucose levels, and that will transmit the data to the receiver, or it is transmitted to the smartphone app. That is the mechanism of action of these CGM devices. Now, what is the advantage of these CGM devices? The advantage is that it is providing you the real-time blood glucose levels, right? It is providing you the real-time blood glucose levels, and thereby it will reduce the risk of the hypoglycemia, and it improves the glycemic control. That is the advantage of the CGM, right? But there are some limitations for this CGM. What are the limitations? See, the limitations is that these CGMs, they require the calibration. That is one of the limitation. Okay. And next important is sensor replacement every few days has to be done, right? The sensor replacement has to be done every few days, right? And sometimes there may be signal delays also. These are the limitations of the continuous glucose monitoring. Now, in which group of individuals you require this CGM? So this is used in patients with type 1 diabetes mellitus, also used in the patients with the type 2 diabetes mellitus. And apart from this, also used in GDM patients, that is gestational diabetes mellitus. And even during intensive insulin therapy, right? Intensive insulin therapy. Okay, so this is the scenario where you require the continuous glucose monitoring devices. Now, what are the popular brands? There are many brands which are available in the market. And these are all the various companies of the CGMs. Okay, now the indications for use, that means what is a definitive indication? For example, if the patient is complaining that there is a frequent hypoglycemic episodes, that is one indication for use. And or if there is poor glycemic control in spite of medical management, or the patient is requiring intensive insulin therapy. That is the indications for use of continuous glucose monitoring. And what are the contraindications for CGM? Because it has to be placed over the skin, skin infections, it is one of the contraindication. Next is allergies, right? Allergies to adhesives is another important contraindication. Next, inability to use technology properly, right? Because it has the sensor, it has the receiver, right? It has a smartphone app. So if there is inability to use the technology properly, that is also the contraindication. And if you see the cost of these particular CGM, it is very expensive, right? Very, very expensive. Okay. So that is about the CGM, that is continuous glucose monitoring. So we have professional and personal types of CGM. And CGM has a sensor, transmitter, and as well as a receiver. The advantage is it will provide real-time blood glucose levels, right? But the limitation is it requires calibration and sensor replacement. And it is the clinical application is both in type 1, type 2 diabetes mellitus and gestational diabetes mellitus. The indications for users, those individuals who are having frequent hypoglycemia, poor glycemic control, and requiring intensive insulin therapy. Contraindications will be skin infections, allergy to the adhesives, and those individuals who are having inability to use the technology properly, right? Now, that is about the CGM, that is continuous glucose monitoring. And very frequently, the questions have been concentrated on the insulin pump therapy, right? Now, if you take the insulin pump, actually, this is a small electronic device. What this small electronic device will do, this will deliver, right? This will deliver continuous subcutaneous insulin infusion, right? This will deliver continuous subcutaneous insulin infusion. Okay, that is the purpose of this insulin pump. And if you take the types of the insulin pumps, we have two types of pumps. One is tethered pump, right? One is tethered pump, and the other one is patch pump, right? The other one is patch pump. You take tethered pump. Tethered pump is that which is having a connection via tubing, right? Which is having the connection via tubing. That is tethered pump. Then you take patch pump. Patch pump, it is tubeless and it is worn directly on the skin, right? It is worn directly on the skin. That is called the patch pump. Now, what are the components of the insulin pump? If you see the components of the insulin pump, you have reservoir which holds the insulin. Then you have an infusion set which contains a cannula and tubing. Then you have a pump that controls the insulin delivery. These are the components: reservoir, infusion set, and as well as pump. Now, what is the mechanism of action of this insulin pump is this will deliver the basal insulin continuously, and it will deliver the bolus insulin whenever the individual have the food. That is the mechanism of action. So it will give basal and it will give bolus insulin. So this will be acting as the artificial pancreas. And what is the advantage of this insulin pump? The advantage of the insulin pump is that it will provide a very good glycemic control. And it reduces the chance of hypoglycemia because it will provide the insulin to the body depending upon the blood glucose levels. And it allows the flexibility in the insulin dosing, right? That is the advantage. What is the limitation? The limitation is that when the patient is on insulin pump, this requires the frequent monitoring of the glucose, right? This requires the frequent monitoring of the infusion pump. This requires the frequent monitoring of the infusion site. And there is also risk of the pump failure. So that is the reason why the frequent monitoring of the pump is very much required. Then what are the clinical implications? In which scenario this insulin pump is required? It is required. It is required in type 1 diabetes mellitus and type 2 diabetics who are requiring the insulin. Usually type 2 diabetes mellitus, they don't require insulin, but in the later stages or in cases of acute illness with type 2 diabetes mellitus, they will be requiring insulin, right? Then, okay. What are the important brands of the insulin? We have multiple companies. Most commonly used is Medtronic company, right? Now, the indications for use of the insulin pump is those individuals who are having poor glycemic control, right? Those individuals who are having poor glycemic control on multiple daily injections, right? The patient is taking multiple daily injections, but there is poor glycemic control. In such case, the insulin pump has to be placed, right? So this is about the insulin pump, and you need to know the contraindications. So contraindications is that patients who are unwilling or unable to manage the insulin pump, don't place the insulin pump in those individuals. And those individuals who are having severe cognitive impairment, please don't place the insulin pump in those individuals. And those individuals who are at risk of the skin infections, don't place the insulin pump in those individuals, right? And what is the cost? It is high upfront cost, right? It is very expensive. So that is about the insulin pump. So to quickly recap the insulin pump, it is an electronic device that delivers the continuous subcutaneous insulin infusion. We have tethered pumps and as well as the patch pumps. The components will be reservoir, infusion set, and as well as a pump. It delivers the basal insulin and as well as the bolus insulin. The advantage is it will improve the glycemic control. But the only limitation is you need to do the frequent monitoring of the pump because pump failure can be there. Used in type 1 and type 2 diabetes who is requiring insulin. And the popular insulin brand is Medtronic. The indication is those individuals who are having poor glycemic control with multiple daily injections. Contraindications is that those individuals who are having cognitive impairment, unwilling or unable to manage the insulin pump, and if there is a high risk of skin infections. And these are highly expensive. Okay, so this is about your insulin pump. Now, let me discuss about the diabetic ketoacidosis, which is one of the most common acute complication in type 2 diabetes mellitus, right? So your diabetic ketoacidosis, it is observed in both type 1 and type 2, but it is more common in type 1 rather than type 2 diabetes mellitus, right? And if you take the glucose levels in these patients with the diabetic ketoacidosis, the glucose levels will be more than 250 milligrams per deciliter. Right? Glucose levels will be more than 250 milligrams per deciliter. And the characteristic features in case of the DKA is that these patients, they have absolute or relative insulin deficiency. That is the problem in patients with the DKA, right? And at the same time, there will be acid-base abnormality. That is because of the ketone body formation, where the ketone bodies are acidic in pH. And if you take the clinical features in these patients with the DKA, they'll have polyuria, polydipsia, abdominal pain, vomiting, tender abdomen. And if you take the respiratory pattern, they will have a periodic breathing that is called as the Kussmaul's respiration. And because there is polyuria, they will have hypotension and they will also have tachycardia. They will also have tachypnea. And on examination, you will have the abdominal tenderness. And these ketone bodies, they are fruity in order. So they will have the fruity breath in the order. So this is about the clinical features of the diabetic ketoacidosis, right? Next, if you take the pathophysiology of the DKA, so two things. Number one, there will be absolute insulin deficiency. And number two, there is excessive increase in counter-regulatory hormones like glucagon, catecholamines, thyroid, corticosteroids, and growth hormone, which will increase the blood glucose levels, right? So insulin deficiency is there. And at the same time, there is increase in the counter-regulatory hormones. Now, these patients with diabetic ketoacidosis, if you take the laboratory abnormalities, they are characterized by a triad. What is a triad? Number one, the blood glucose level will be more than 250 milligrams per deciliter. Number two, the ketone bodies will be positive. And number three, the pH will be acidic pH, right? Acidic pH, where the pH will be less than 7.3, right? And this acidosis, it is high anion gap metabolic acidosis. So this will be the triad in patients with the diabetic ketoacidosis. Now, if you take the ketone bodies, you have acetone, acetoacetate, and beta hydroxybutyrate. And beta hydroxybutyrate does not appear in the urine because it is highly acidic in pH, right? That is the reason why beta hydroxybutyrate does not appear in the urine. So that is the reason why the investigation of choice will be plasma ketone bodies, but not the urine ketone bodies. So this is about the laboratory abnormalities. Now, do you have any form of euglycemic decay? Yes, there is also a form of euglycemic decay. Here, the glucose levels will remain normal. And in which scenario you will have this euglycemic decay? Those individuals who are taking SGLT2 inhibitors, right? Those individuals who are taking SGLT2 inhibitors, they are the one who will have the euglycemic decay. Now, coming to the treatment of decay, in the treatment of decay, the first line therapy will be the fluid replacement. And among the fluid also, what is required is the normal saline, right? And followed by that, for volume correction, what is required is the half normal saline is required, right? So, but the initial thing is the IV fluids. Then followed by that, the insulin infusion should be given, right? And this insulin infusion should be given in the form of the intravenous route. And the type of insulin is the regular insulin, right? The type of insulin is the regular insulin should be given, right? And this particular regular insulin, it should be given in the form of bolus, right? Initially, then followed by that, it should be given in the form of infusion. Okay, and the infusion you need to give at a rate of 0.1 unit per kg. Infusion is what you need to give. And when the blood glucose levels reaches 150 milligrams per deciliter, at the same time, you need to add dextrose to these patients. And the insulin infusion has to be carried out until the ketone bodies become negative. Only when the ketone bodies become negative, then the insulin infusion has to be stopped. And whenever you are giving insulin infusion, potassium monitoring has to be done because insulin is the one which will shift the potassium from extracellular compartment to the intracellular compartment. Okay, so and potassium monitoring and as well as the electrolyte management is very, very important. And once the potassium levels are less than 5, actually the normal value of the potassium is 3.5 to 5. Even if the potassium drops down less than 5, you need to give the potassium supplementation. Next is the treatment of the acidosis and as well as the bicarbonate therapy. When will you give bicarbonate or when will you treat the acidosis is when the pH is dropped to less than 7, that is severe form of acidosis, you need to give intravenous sodium bicarbonate. Or when the bicarbonate levels, it has reduced to less than 10 milliequivalents per liter, right? When the bicarbonate levels has reduced to less than 10 milliequivalents per liter, that is the point when you need to give the bicarbonate. Okay, so acidosis and bicarbonate therapy should be, bicarbonate therapy should be given when the sodium bicarbonate levels are less than 10 milliequivalents per liter or when the pH is less than 7. Next is the phosphate and as well as the magnesium. So hypophosphatemia is very common. You need to monitor for the phosphate level, right? And supplementation of the phosphate should be given when the phosphate levels are less than 1 milligrams per deciliter. And what are the complications for the DKA? Please remember the most common cause of death in patients with the DKA will be the cerebral edema. All these patients, they have to be admitted in ICU and they have to be monitored. The other complications will be thrombosis, respiratory distress, and as well as the gastrointestinal bleeding, right? And what is the chance of mortality in patients with the DKA? The chance of mortality is less than 1%. And it all depends upon if there is underlying infection or if there is any development of myocardial infarction. So this is about the DKA. So to quickly recap about the DKA, DKA is very common in type 1 rather than type 2 diabetics, right? And in DKA, the blood glucose levels will be more than 250 milligrams per deciliter. The ketone bodies will be positive. pH will be acidic in pH. These three are very, very important. And it will be high anion gap metabolic acidosis, right? And pathogenesis, if you see, it is absolute insulin deficiency and there is increase in counter-regulatory hormones of the blood glucose. That is a pathophysiology. right? And euglycemic decay is observed in those individuals who are taking SGLT2 inhibitors. And in the treatment, the first line treatment is the IV fluids, that is normal saline. Followed by that, insulin bolus and infusion should be given. And whenever you're giving the insulin, you need to monitor the potassium because there can be hypokalemia. And when the pH is less than 7, you need to give intravenous sodium bicarbonate. And when phosphate levels are less than 1 milligram per deciliter, then you need to give phosphate. Complications will be cerebral edema. That will be the cause of death. And mortality is less than 1%. So this is about the decay, diabetic ketoacidosis, right? Next important part of the diabetes that we need to discuss is about the maturity onset diabetes of young and as well as the LADA, right? So what is this LADA? Latent autoimmune diabetes of adults. So if you take these two, right, out of this, you take MODI, that is maturity onset diabetes of young. This is insulin non-dependent, right? Insulin non-dependent. Whereas LADA, it is insulin dependent. Right, LADA, it is insulin dependent. So if you see the definition of the MODI, it is due to gene mutation, and it is a monogenic form of diabetes mellitus. Right, it is a monogenic form of diabetes mellitus, right, and which is caused due to mutation in the specific genes. Right, mutation in the specific genes which is affecting the insulin secretion. Then what is LADA, latent autoimmune diabetes of adults? It is the pathogenesis is autoimmunity. In MODI, it is due to gene mutation. LADA, it is autoimmunity. What is the age of presentation? If you take MODI, the age of presentation is around 20 to 30 years, but average it is around 25 years, right? Whereas LADA, it is typically observed in adults, that is over the age of 30 years. Actually, after 30 years, what you have is type 2 diabetes mellitus. But after 30 years, if there is autoimmunity causing beta cell destruction, that is what is called LADA, right? And in case of MODI, it is due to gene mutations, I've said. And how are these genes mutated being inherited? The type of inheritance is the autosomal dominant type of inheritance. Whereas in case of LADA, what is that we have discussed? It is autoimmune destruction of the pancreatic beta cells, similar to that of diabetes mellitus. Now, what are these antibodies that will be destroying the beta cells? The antibodies that will be destroying the beta cells will be the anti-GAD antibodies, then islet cell antibodies, right? So these are the antibodies against the beta cells. That is what you will have in case of LADA. Then you take the genetics in case of MODI. So as I have said you, the type of inheritance is autosomal dominant type of inheritance. What are the genes mutated? Actually, if you take MODI, we have multiple types of MODI starting all the way from MODI 1 to MODI 6. Out of all these, the MODI 3 is the most common type of MODI. And in case of MODI 3, what is the gene that is being mutated is the HNF1 alpha is the gene that is being mutated. And in other forms of MODI, we have HNF4 alpha and as well as glucokinase gene, GCK gene is being mutated. Then you take LADA. In case of LADA, it is polygenic with associations to the HLA. That means there is an HLA association in case of the LADA, right? And if you take the pathophysiology, as already I have said to you, that there is defective beta cell function in case of MODI. Why? The defective beta cell function is mainly because of the presence of the gene mutation. Whereas in case of LADA, it is beta cell destruction, right? There is progressive loss of insulin producing beta cells due to autoimmune attack, right? Due to autoimmune attack. That is what you will see in case of the LADA, right? Now, you take the presence of autoantibodies. Do you have autoantibodies in case of MODI? No, autoantibodies are present only in case of LADA, that is GAD antibodies, that is glutamic acid decarboxylase antibodies. Then islet cell, that is insulin antibodies, right, IA2. Then zinc transporter 8 autoantibodies. These are the autoantibodies, GAD, IA2, then zinc transporter 8 autoantibodies. Then if you take the clinical features in case of MODI or LADA, there will be hyperglycemia. Because there is hyperglycemia, these patients will have the polydipsia and as well as polyuria, right? And in which two forms you have the family history? Because your MODY is due to gene mutation and the inheritance is autosomal dominant type of inheritance. In MODY, you have strong family history, right? But in case of LADA, you don't have the strong family history. You don't have the strong family history in case of LADA. And then how will you diagnose MODY? It is being done by the genetic testing. Genetic testing is the one which will demonstrate that there is HNF1 alpha gene mutation. Then the other thing is the glucose levels, C-peptide levels, autoantibodies will be absent. Whereas LADA, you have the presence of the autoantibodies, right? Then what will happen to the insulin level and C-peptide levels in case of LADA? There will be declining C-peptide and declining insulin levels because there is loss of beta cell producing cells. And what is the treatment? In case of MODY, there is a beta cell dysfunction. So in case of MODY, you don't require to give the insulin. What is required in case of MODY is low dose sulfonylureas are being given, right? Low dose sulfonylurea is the drug of choice, right? That will be the drug of choice. And insulin is not required in case of MODY. Whereas you take in case of LADA, there is loss of beta cell producing insulin. So insulin therapy is required in case of LADA, but not in case of MODY, right? So this is about the MODY and as well as the LADA. So to quickly recap about these two, so MODY, it is non-insulin dependent. LADA, it is insulin dependent. MODY, due to gene mutation and autosomal dominant type of inheritance, and MODY3 is more common, and HNF 1 alpha is the most common gene mutation. LADA, it is autoimmunity, then the autoantibodies are GAD antibodies, then islet cell antibodies, then zinc transporter 8 antibodies, right? Family history, strong family history is there in MODY, but not in case of LADA. Treatment, MODY, low dose sulfonylurea. LADA, insulin therapy has to be given, right? So this is the difference between MODY and as well as LADA, right? Then lastly, let me discuss about the diabetic retinopathy and as well as the diabetic nephropathy. So these two are the microvascular complications. And these two microvascular complications, they are completely depends upon the levels of the HbA1c. Right? It is completely depend upon the levels of the HbA1c. And if the HbA1c is more than 7%, then there is high chance of microvascular complications, that is diabetic retinopathy and as well as the diabetic nephropathy. And not only that, even diabetic neuropathy is also very, very common, right? Now, so you see this, you take diabetic retinopathy. Diabetic retinopathy, this is one of the leading cause, right? This is one of the leading cause of the vision loss. Whereas diabetic nephropathy, this is one of the leading cause of development of end-stage renal disease, that is CKD, that is diabetic nephropathy, right? Then, if you take diabetic retinopathy, as I have said you, it is a major cause of blindness in the age group of 20 to 74 years. And diabetic nephropathy, as I have said you, this is the most common cause of end-stage renal disease where there is requirement of dialysis. And this diabetic retinopathy, we have two types. One is non-proliferative and the other one is proliferative diabetic retinopathy. Which is the early stage of diabetic retinopathy? That is non-proliferative. What is the advanced stage of the diabetic retinopathy? That is, the advanced stage of diabetic retinopathy will be the proliferative diabetic retinopathy, right? Whereas you take diabetic nephropathy. In diabetic nephropathy, the first stage, right? The first stage will be increase in the GFR, right? Increase in the GFR will be the first thing that you will have in case of diabetic nephropathy. Followed by that, there will be microalbuminuria. In the later stages, there will be macroalbuminuria. Followed by that, there will be decline in the GFR. But the first thing is, you will notice that there is increase in the GFR. Now, what is the pathophysiology? So, in case of diabetic retinopathy, it is a microvascular disease that will be causing retinal ischemia, and there will be also loss of the pericytes, right? Retinal ischemia and loss of pericytes. Whereas in diabetic nephropathy, what did I tell you? The initial stage is increase in the GFR. So there will be glomerular hyperfiltration due to increase in glomerular permeability. That will be there initially. And as the glomerular permeability is increasing, there will be microalbuminuria and macroalbuminuria. And what will be the clinical manifestations? In case of diabetic retinopathy, when you do a fundus examination, you will notice that there is microaneurysms, blot hemorrhages, and there will also be cottonwool spots, neovascularization, and as well as the macular edema, right? And you need to know that in diabetic retinopathy, there will be visual loss. What is the cause for visual loss? In case of proliferative diabetic retinopathy, it is the retinal detachment. Whereas in non-proliferative diabetic retinopathy, it is the macular edema, right? It is macular edema. Okay, this will be the clinical features. And what are the risk factors for diabetic retinopathy? Very important, as I have said you, poor glycemic control. When the HbA1c is more than 7%, that will result in diabetic retinopathy. Associated with that, if there is dyslipidemia and nephropathy and hypertension, these are the associated risk factors. And how will you examine for diabetic retinopathy? Initially, fundus examination. Followed by that, the other investigations will be the fluorescent angiography and then optical coherence tomography, that we call it as OCT. That is your diabetic retinopathy, right? Now, what are the clinical features of the diabetic nephropathy? Diabetic nephropathy, there will be albuminuria. So initially it will be microalbuminuria, where the albumin levels will be more than 30 milligrams per grams. But as the severity progresses, it will go up to more than 300 milligrams per gram also. More than 300 milligram per gram of creatinine. And that we call it as macroalbuminuria. Followed by that, there will be reduced GFR, hypertension, and as well as edema. That is what you'll observe in case of diabetic nephropathy. And what are the risk factors for diabetic nephropathy? Same thing. Poor glycemic control. When the HbA1c is more than 7%, there is a chance of diabetic nephropathy. Then family history, smoking, and as well as the obesity. And how will you diagnose for diabetic nephropathy? You need to do the urine albumin to the creatinine ratio. That is the ideal method for doing or estimating the urine spot albumin. Followed by that, in atypical cases, they will be requiring the kidney biopsy. And in the kidney biopsy, what is the pathognomic lesions? The pathognomic lesions in diabetic nephropathy will be KW lesion, which is called Kimmel-Wilson's lesions, or which is also called intercapillary glomerulosclerosis, right? So what are the complications that you will see in both of these patients? In diabetic retinopathy, the complication is vitreal hemorrhage, and there will be retinal detachment. Because of retinal detachment, as I have said you, in proliferative diabetic retinopathy, there will be blindness. Whereas non-proliferative diabetic retinopathy, the blindness is mainly due to macular edema. And diabetic nephropathy patients, they progress to end-stage renal disease, where the GFR will be less than 15 ml per kg per 1.73 meters square. And because of the fluid overload due to the chronic kidney disease, these patients will also have the cardiovascular abnormality. And whenever you're treating in diabetic retinopathy, in both of them, strict glycemic control is very important. Followed by that, the laser photocoagulation and as well as anti-vascular endothelial growth factor therapy. What is that anti-vascular endothelial growth factor therapy? That is intravitreal bevacizumab. Right, intravitreal bevacizumab. The other important treatment is vitrectomy. So this will be the treatment and prevention that you'll be doing in case of diabetic retinopathy. Whereas in diabetic nephropathy, ACE inhibitors, they are considered as drug of choice. Why? Because ACE inhibitors, they cause efferent arteriolar dilatation and they reduce the intraglomerular pressure, reducing the proteinuria. The other drugs which will prevent the progression of diabetic nephropathy will be SGLT2 inhibitors. And once the individual goes into end-stage renal disease, renal replacement therapy is required, right? And how will be the prognosis? See, without intervention, the prognosis will be bad in case of diabetic retinopathy. But if you do early detection is the one which will improve the outcome in case of diabetic retinopathy. The same way is diabetic nephropathy also. So without the monitoring, the individual will go into a stage of end-stage renal disease. And once the individual goes into end-stage renal disease, they will be requiring the renal replacement therapy. And that renal replacement therapy will be either in the form of dialysis or in the form of the kidney transplantation. Okay, so this is about the two important complications, that is diabetic retinopathy and as well as diabetic nephropathy. Now we'll do the multiple choice questions. Right. Some of the clinical based questions on the topic of diabetes mellitus. Okay. So we have a 45-year-old male with type 2 diabetes. He started on the CGM, that is continuous glucose monitoring. Which of the following is a key advantage of the CGM over SMBG? Go through all the options. CGM eliminates the need for insulin therapy. CGM provides real-time glucose trends and alerts for hypoglycemia. CGM measures blood glucose directly instead of interstitial glucose. CGM requires no calibration and works indefinitely. Yeah, any one of you? Which of the following is the key advantage of CGM over the self-monitoring of the blood glucose? Yes. So if you take the advantage of the CGM, the advantage of the CGM is that the CGM, yeah, very good, Alina. So CGM, it provides the real-time blood glucose trend and it will alert the hypoglycemia. Whereas SMBG, it provides isolated readings. Whereas continuous glucose monitoring, it offers continuous monitoring of the blood glucose. Okay. So the advantage of the CGM over SMBG is the second option, right? Next question. A 30-year-old woman with type 1 diabetes mellitus, the patient is initiated on the insulin pump therapy. Which of the following is not a potential complication of the insulin pump therapy? Not a complication. Diabetic ketoacidosis, infusion site infection, increased frequency of severe hypoglycemia, then improved flexibility in insulin dosing. Yes. Right. So the advantage of the insulin pump is that, or not a potential complication is, the insulin pump, it provides the improved flexibility in the insulin dosing, right? Very good, Alina. So this will provide the improved flexibility in insulin dosing. Okay. So whenever there is pump failure, there is chance of diabetic ketoacidosis. Whenever there is, or there can be infusion site infection, and there is increased frequency of the severe hypoglycemia also. But improved flexibility in insulin dosing is not a potential complication. Okay. Next question. We have a 14-year-old girl presents with polyuria polydipsia and blood glucose levels are 310 milligrams per deciliter. ABG showed pH of 7.1 and anion gap is 20. What is the next step in the management of this patient? Administer subcutaneous insulin and discharge home. Start IV fluids, IV insulin and electrolyte replacement. Prescribe metformin and lifestyle modification. Perform a CT scan of the brain to rule out cerebral edema. So in case, what is this diagnosis? It is a DKA, diabetic ketoacidosis. Okay. Now, in case of DKA, what is the first line treatment that we have discussed? In case of DKA, the first line treatment will be start IV fluids, IV insulin, infusion, and then electrolyte replacement has to be done depending upon the scenario. And that too, it is a potassium replacement has to be done. Right? Yes, very good, Alina. Next question. Which of the following features is most characteristic of MODY compared to type 1 and type 2 diabetes mellitus? Presence of diabetic autoantibodies, onset after 40 years, autosomal dominant inheritance pattern, severe insulin resistance, and obesity. Yeah. Most characteristic feature of the MODI. Yes. So most characteristic feature of the MODI is what? That is autosomal dominant type of the inheritance, right? Presence of diabetic autoantibodies. It is a feature of LADA and it is a feature of type 1 diabetes mellitus. Onset after 40 years, seen in case of LADA and case of type 2 diabetes mellitus. Severe insulin resistance and obesity, it is observed in type 2 diabetes mellitus, right? So here the answer is C. Okay, good. Next question. We have a 55-year-old man newly diagnosed with LADA. Which of the following features differentiate LADA from type 2 diabetes mellitus? Insulin resistance, rapid progression to insulin dependence, absence of autoantibodies, good response to sulfonylureas. Which features differentiate LADA from type 2 diabetes mellitus? So, insulin resistance, it is a feature of type 2 diabetes mellitus, but it is not the feature of LADA. Absence of autoantibodies, it is a feature of type 2 diabetes mellitus, but it is not LADA. Good response to sulfonylureas, it is a feature of type 2 diabetes mellitus, but it is not LADA, right? Yes. So rapid progression to insulin dependence, because in LADA, there is loss of insulin producing beta cells, and that will result in the requirement of the insulin, right? So rapid progression to insulin dependence is observed in case of type 2, LADA. Next question. So we have a 60-year-old diabetic patient presents with gradual visual loss. Fundoscopy reveals microaneurysms, blood hemorrhages, and neovascularization. What is the next best step in the management of the patient? Strict glycemic control and blood pressure control, prescribe aspirin therapy, perform immediate vitrectomy, discontinue antihypertensive medications. So basically, what is the diagnosis here? The diagnosis is diabetic retinopathy. And in case of diabetic retinopathy, only when there is development of the visual loss, for example, retinal detachment in proliferative diabetic retinopathy causing visual loss, there you need to give the intravitreal bevacizumab, right? But when the visual loss is not there, it is just strict glycemic control and as well as blood pressure control is very important here. Okay, so the answer is A. Next question. 55-year-old diabetic patient with hypertension presents with persistent proteinuria and a declining EGFR, right? Persistent proteinuria and declining estimated GFR. What is the best treatment to slow the progression of the diabetic nephropathy? Start metformin, prescribe ACE inhibitors, recommend a high protein diet, administer diuretics only. So, is proteinuria. What is the drug of choice? The drug of choice is ACE inhibitors. What these ACE inhibitors will do? They will reduce the intraglomerular pressure by causing efferent arteriolar dilatation. And what are the other group of drugs? That is SGLT2 inhibitors. They also prevent the progression of the diabetic nephropathy, right? So but here the answer is B. Okay. Metformin, it will only reduce the insulin resistance, but it is not the treatment that we give in case of diabetic nephropathy. And high protein diet should be avoided because already there is proteinuria. When you are giving high protein diet, the proteinuria will get further precipitated. And there is no role of giving the diuretics in case of diabetic nephropathy, where there is declining estimated GFR. Okay, next question. A 65-year-old man with diabetes is started on glucocorticoid therapy for an autoimmune condition. What impact do glucocorticoids have on glucose metabolism, and how should diabetes management be adjusted when the individual is on steroid therapy? Decrease insulin dose to prevent hypoglycemia, increase insulin or OHA due to steroid-induced hyperglycemia. Glucocorticoids have no effect on glucose levels. Only fasting glucose is affected. Postprandial levels remain normal. Yeah. What is the correct statement? When the patient is on glucocorticoid therapy, what is the treatment? Right. So the correct answer here is you need to increase the insulin or OHA due to steroid-induced hyperglycemia. Because what these glucocorticoids do is they increase the hepatic gluconeogenesis. They increase the glucose levels. That is the reason why you need to increase the insulin or the OHS. Okay. Next. A pregnant woman with gestational diabetes mellitus is concerned about the effects of hyperglycemia on her baby. What is the most common neonatal complication? What is the most common neonatal complication? Hypoglycemia, hyperglycemia, pancreatic insufficiency, microcephaly. Yeah, anyone? Right. So here the correct answer is, anyone? What is the most common neonatal complication? Right, very good, Alina. So it is the hypoglycemia. Hypoglycemia is the most common neonatal complication. What could be the reason? The reason for the hypoglycemia is because of the fetal hyperinsulinemia, right? So why there is fetal hyperinsulinemia? That is in response to maternal hyperglycemia. Gestational diabetes mellitus will cause maternal hyperglycemia, right? And in response to maternal hyperglycemia, the fetal insulin level increases. And as the fetal insulin level increases, that will induce the hypoglycemia. That is what is common in case of the gestational diabetes mellitus, right? And one last question. A 35-year-old HIV positive patient on antiretroviral therapy develops the features of lipodystrophy and insulin resistance. What is the best initial treatment strategy? Discontinue antiretroviral therapy, start metformin therapy, prescribe corticosteroids, advise the high-fat diet. Right. So as such, if you take the HIV-associated lipodystrophy, HIV-associated lipodystrophy, it is the one which will cause the insulin resistance, and insulin resistance is the one which will be responsible for the glucose intolerance, right? Will be responsible for glucose intolerance. Now, whenever there is insulin resistance, what is the drug of choice? Metformin is the preferred treatment, right? And your antiretroviral therapy should not be discontinued. It should be continued, and along with that, metformin should be given. Okay, so start metformin therapy is a correct statement. Okay, so this is about the important points related to diabetes mellitus and some of the clinical based questions. So tomorrow at 6 p.m., we will be having the discussion on thyroid disorders, hyperthyroidism, hypothyroidism, monitoring of the thyroid treatment. Then I will also be discussing about the complications of thyroid, that is thyroid storm and as well as myxedema coma. So that will be tomorrow 6 p.m. the discussion will be. Okay. So with this, I wind up this particular section. Thank you very much.